Our topic today is the review of the protocol changes for 2018. We will make protocol changes. They're going to be effective January 1st. ResponseSoft will update your phone app and your tablet app the evening of December 31st. We'll also have print versions available later this month or into December. When you open up the app for the first time after the update, you should see a prompt that asks if you would like to update the application. Always click the yes option so that you can update the app and have the most current version of the protocol available to you. We spent a lot of time on the protocol. We try to make some things simpler, and you'll see there have been a couple protocols that have been changed or consolidated to make things easier for you. The approach today is going to be really two-armed. We're going to talk about significant protocol changes where I will show and discuss the algorithms for each protocol of concern. And then at the end, I'll just go through some general cleanup items, things that we've changed, made some adjustments to, but I didn't really want to spend a whole slide or two for that change. A lot of these cleanups have been typographical. Some of them have to do with clarity of how things are outlined, and some of them have to do with changing phone numbers and contact information. Also, for today's conversation, continuing education credit is available. In order to get the credit, you have to complete the questions that are embedded within this discussion. All of our protocol changes will be found at the end of the protocol. There are several pages, and it lists each of the changes. And if you click on the bolded text on the app, the bolded text, by clicking on it, will take you directly via hyperlink to the protocol that's being discussed. I suggest that you review these changes and at least be comfortable with the changes, and then look at the individual protocols as necessary to refresh your memory. So talking about major revisions, let's start with allergic reaction and anaphylactic shock. This is one of those protocols where we consolidated two into one. So in the past, we had a protocol for mild to moderate allergic reactions and then one for severe allergic reactions and anaphylaxis. We just put them all together. And we think this will make it easier for you. And we moved epinephrine to the top of the algorithm, and we did that because whether you're talking about mild allergic reactions or severe, epinephrine is the cornerstone of treatment. We've talked about that during previous MEC minutes, and regardless of severity, if the patient shows evidence of allergic reaction, they should get epinephrine. We've continued to have albuterol and Atrovent as available for bronchodilators if the patient has evidence of acute bronchospasm, and then Benadryl or diphenhydramine and Decadron or dexamethasone also remain as cornerstones of treatment. We've also de-emphasized warnings having to do with using epinephrine in patients with cardiac disease. In fact, we've taken that off as a warning, so that if you have a patient with allergic reaction, have history of cardiac disease, hypertension, or they're elderly, if they have allergic reaction, they should get epinephrine. Studies have shown that the side effects or risks of epinephrine for treatment of allergic reaction in the elderly or patients with coronary artery disease really are low, and there's greater threat to the patient's health and well-being by not treating the anaphylaxis or allergic reaction. So epi is king. For respiratory distress, we have also de-emphasized epinephrine or the warnings regarding epinephrine, although we advise that you use some caution when using epinephrine for patients who have used bronchodilators repetitively. We have reviewed and revised the RSI or rapid sequence intubation protocol. We've simplified it to the point where you probably can't call it RSI anymore, but that's what we're going to continue to do. That's what we know it as. So one of the things we did is we removed the requirement for pre-medication with fentanyl and midazolam, so that if you think the patient needs an airway, we're going to pre-oxygenate them with high-flow oxygen via non-rebreather mask, set them up with cardiac monitors, get your equipment set up, and then we're going to sedate and paralyze with ketamine and rocuronium. And then we've also clarified sedation for transportation. So now, once the patient is intubated, they should get fentanyl and midazolam as needed to maintain sedation. The fentanyl dosing is a consistent 2 micrograms per kilogram regardless of age, and there is no dose limit. So if the patient's 200 kilos and they need 400 mics of fentanyl, that's what you give them. Midazolam is now weight dose, but it's also got a dose of 2 milligrams for adults. And then midazolam and fentanyl can be repeated every 20 minutes as necessary for transport and to maintain sedation. We've allowed the doses to be repeated times 2. I figure that within 40 minutes you should be able to get the patient to a receiving facility where continuing sedation can be ordered by the attending physician. We've also changed the location of RSI. It's now moved out of the procedure section and moved to the adult respiratory section of the protocol. So you'll find it in a different location. I have CPR listed here not because we've made any changes, but because of some questions I received about how we have our cardiac arrest algorithms developed and what the role respirations or ventilations have. And rather than make any changes to those protocols, I'm referring everybody back to the CPR section, which talks about the sequence of compressions and ventilations and so on. And I think this covers those questions adequately, and we don't need to make any additional protocol changes to the cardiac arrest algorithms for kids or for adults. We've made some changes to the pediatric primary assessment, and Dr. Stoner essentially rewrote Section 5, which has to do with assessing the adequacy of breathing. I would suggest that you take a look at it. It does indicate that we're going to use oxygen as necessary to maintain an O2 saturation better than 94%, and that if a child requires ventilatory assistance, we're going to give them 100% oxygen via BVM, and discourages the use of neonatal size ventilation bag in the field. So take a look at this and make sure you're aware of the changes. We have also taken our ALTI algorithm or protocol and reworded it. ALTI has now become BRUE, or BRUE, which stands for Brief Resolved Unexplained Event. Really, the algorithm is very similar to the ALTI algorithm. We've made some changes in terms of moving it from ALTI to BRUE. And then under the first box, we've revised item number 4 to change in breathing and altered level of consciousness. So I don't think these are big changes other than terminology, but we wanted to bring our terminology to what's currently being used. For pediatric pain control, we have added a box and a pathway where intranasal fentanyl is encouraged, and I would encourage you to look at this and consider intranasal fentanyl for children who have significant pain. We tend to use this particularly in children with significant orthopedic injuries, but you don't need to wait for IV access. You can give intranasal fentanyl in children, and I know my experience is the parents are very appreciative when we do that. We can also use intranasal fentanyl for adults if IV accesses are difficult or you don't have time to get an IV started. So don't forget about using intranasal fentanyl in adults if there's a need for pain control. For pediatric neonatal care, we have removed the recommendations of suctioning meconium out of the trachea and so on. This has been de-emphasized by the pediatric literature. So now in newborns, whether there's meconium or not, we dry the child off, keep them warm, and then use the bulb suction to clear the mouth and the nose. If the child is having ventilatory difficulties, then we're going to ventilate them with the BVM and give them 100% oxygen, because these children need oxygen. So if you look at pediatric or infant resuscitation of the newborns, the emphasis now is using bulb suction to clear the mouth and nose and then ventilate the child. We do not use a suction device to suction meconium from the trachea or the lungs. For pediatric seizures, and we've done, for pediatric seizures, we have essentially taken the febrile seizure protocol and combined it with the other seizure protocol. So now it's the same protocol. The emphasis is on intranasal midazolam for adults and children for any patient who is having an active seizure. So if you arrive on scene and the child is having an active seizure, your first priority is to get them in a safe position, then to use intranasal midazolam or Versed. This is no different than what we've been talking about over the past couple of months through MEC-Minute and dosing of the child with midazolam. And then if you think the child has a fever, you check their temperature and give them ibuprofen if they're able to take medications orally. So we essentially have combined the febrile seizure protocol with the pediatric seizure protocol. I think you'll find this much easier. Really, there's no reason to have a separate protocol because if the child's having a seizure, we're going to treat the seizure. If the child is postictal, we're going to check a blood sugar, check a temperature, and get them to the hospital. Pediatric allergic reactions, we have pretty much combined them as well, combined the mild and moderate with the severe. The format's a little bit different than what you saw with the adult, but again, epinephrine is the first medication to be given, and we want that to be given early. So no real change in terms of dosing schedules. It's more a matter of how the algorithm is plotted out, and that extra emphasis on early administration of epinephrine for any allergic reaction. Talking about some of our clinical standards, we now have an EMS branch operations clinical standard. It has to do with what happens when there is a significant medical event, particularly a mass casualty event. This is a new clinical standard, and it's the first time it's posted in our protocol. It has been developed with input from our battalion chiefs, and it's my understanding the battalion chiefs have also had training on this. I've duplicated the 3 pages out of it. I would encourage you to take a look at it and to read it thoroughly. So the first page has to do with operations and a triage officer. The second page of the branch operations standard has to do with assignment of a treatment officer and a transportation officer. And then the third slide has to do with start triage, which is our preferred method of triage in the field. So I don't think there's anything here that should be surprising or new to you, but it formalizes our process in terms of how the scene will be set up as the scene and the response progresses. So I would encourage you to read it. I would suggest that you train on it and make sure that you have knowledge of this in case we have the fortunate event where we have to use it. We have looked at our termination and resuscitation process. I know I've posted some comments on Workplace, but we have simplified or tried to simplify the TOR process so that there's a checklist. And the checklist includes those components that we have listed previously about indications for termination, but we've also included the exclusion criteria so that you have one document you can refer to in making a termination that the patient is suitable for termination and resuscitation. So I would again encourage you to read it. There are no surprises here. We have just focused on making it easier for you to understand, and we now have a checklist available for your use. I have thrown up here the slide or the information on the MAD device, and this is really no different than what you're used to seeing with our changes we made this past summer. I just want to reinforce the layout, which has got the red boxes in the mid-page, so that you understand that Section 2 has some adult dosing, and then underneath that has some pediatric dosing. So for adults, for sedation, it's 5 milligrams intranasally is the preferred route over IV and IO. Again, if you're doing it for sedation only, not for patients who are agitated, they're going to get ketamine. And the adult seizure dose is 10 milligrams with 5 milligrams per nostril. For kids, it's weight-based, and essentially any child over 55 pounds is going to get the adult dose of midazolam. So I just wanted to point out those formatting changes we made in mid-page. I want to make sure they're clear to you so that you understand the dosing in the field. We've also added to our protocol a different pain score for children. It's called the Flacker score. It's listed here. We have not been able to get it set up in ResponseSoft as a pre-calculating formula, but I think it's good for us to start talking about moving into using a Flacker as a way of identifying or quantifying the amount of pain a child is in. If the child's able to look at the smiley faces, or the child's able to give you a 0 to 10 rating, then you can use that as well. But for the child that is small, not able to really point to the face in terms of which face identifies your level of pain, then think about using the Flacker score as part of your documentation in the run report. For protocol cleanup, just some items. For chest pain, we remove the cautions regarding nitrate use in patients with RV infarct or inferior infarct. And that's because there have been some studies published that show that there is no increased risk. And actually, in one study, it seemed that there was an increased risk of hypotensive response to nitrates in anterior MIs versus inferiors and RV infarcts. We've also added a fluid bolus if indicated to the IV and IO section of the protocol for chest pain. For behavioral issues, we have made a standard dose of ketamine as 3 milligrams per kilogram for children and adults, so there's no difference in the dosing schedule. It's 3 milligrams per kilo. For stroke, we have made some changes based on recommendations by the American Heart Association earlier this year regarding patients who may have a large vessel occlusion. So patients with a LAM score of 4 or 5, they are higher risk to have a large vessel occlusion. The treatment of choice for large vessel occlusion is clot extraction, and clot extraction is done by comprehensive stroke centers. So we now have 3 comprehensive stroke centers in town. It's Mount Carmel East, Riverside Methodist Hospital, and OSU Wexner. And the current American Heart Association recommendations are, if you have a patient who screens positive for large vessel occlusion or LVO, that they be taken to a comprehensive stroke facility if the incremental increase in transport time is less than 15 minutes. So if you're in a spot where you can get to a comprehensive facility in less than 15-minute time increase from going to a primary stroke facility, and you have a patient with large vessel occlusion, they should go to a comprehensive stroke center. So as an example, if a primary stroke center is 10 minutes away and a comprehensive stroke center is 20 minutes away, and you have a patient with a LAMS of 4 or 5, they should go to the comprehensive stroke facility. So this is really a medic call. You have a better idea of what your transport times are, but if you have a large vessel occlusion stroke or a patient who screens positive for an LVO with a LAMS of 4 or 5, they should be taken to a comprehensive stroke facility if you can get there in less than 15 minutes incremental increase in transport time. If you have any questions about that, send me an email or post the question on Workplace. But I think we need to really start thinking about transport decisions and getting the patient linked to an appropriate facility. For burns, we've added some recommendations for barrier precautions so that, if you're working with a burn patient, make sure that you have appropriate protective gear on. And if you have a patient who has difficult IV access because of burn locations, you can put an IO through a burn if it's necessary to get access. If you have non-burned areas that are suitable for IO, then use those areas. But if you have no choice, then you can put the needle through a burn. For crush protocol, we've removed the 2-liter fluid restriction. So patients who have major crush injuries, they require large volume fluid resuscitation in order to avoid rhabdomyolysis and renal shutdown. For multiple traumas, we added a caution not to delay transport in order to establish 2 IVs. I think that makes sense, but we wanted to make sure it was clearly stated. If you have a patient who's a victim of trauma, ideally we would like 2 IVs, but don't stay on scene trying to get those 2 IVs started. If you can get them en route, great. If you have to do an IO, that's fine. So you just don't hang it on scene. One thing I didn't add on this sheet that we revised on our trauma protocol has to do with how we place catheters for suspected tension pneumothorax. Still the preferred route is the second intercostal space. We've added a note that you need to make sure you have a long enough needle. We've also, though, added a note that if you have a morbidly obese patient, preferred route is actually to place the needle to relieve tension pneumothorax in the fifth intercostal space, anterior axillary line. So we haven't emphasized that point, but we did put it in the protocol. Another thing that we put in the protocol that I didn't post as a slide is we've added a graphic to the procedure section for cricothyrotomy, so that we now have a graphic that shows how to do a cricothyrotomy in the field. So you might want to take a look at that. For pediatrics, pediatric bradycardia, we added a note to give oxygen early. For most children, bradycardia is treated with oxygen. Their need is oxygen in order to reverse the bradycardia. For pediatric PEA arrests, we added instructions to continue CPR, epi, defib if the child fails to respond to treatment. We increased the bolus requirement for hypovolemic shock from 10 milliliters per kilogram to 20, which is, I think, what most of us were used to doing anyway. And then for pediatric universal assessment, we added an instruction to give Zofran in the truck to avoid refusal. This was based on Dr. Stoner's concern that if we give Zofran in the house, the family may then decline refusal. Well, we want to give it to them in the truck so that we can get them to the hospital. We don't want to be seen as someone who gives Zofran in the field, so we can avoid transport to the hospital. Some pharmacology cleanups. Again, the fentanyl dose for RSI was changed to 2 micrograms per kilogram for adults and children. For magnesium sulfate, the pediatric bronchospasm dose was increased from 25 milligrams per kilogram to 50. And we made some midazolam dosing changes to make it consistent. I think if you look at time and effort put into this new protocol or the protocol revisions, we spent more time and effort working on midazolam than anything else within the protocol. For the clinical standards, child abuse, we added a note that notification of the county's children's services should be added to paragraph 8. Has to do with if you went to a domestic violence scene and children are on site, there's now a recommendation that children's services be notified. We, just to be purists, the trauma triage section was retitled to Ohio Trauma Triage Criteria. It's really not COTS trauma triage criteria. We use COTS format in terms of how we graphically represent it for you, but it's really the Ohio Trauma Triage Criteria. The Rapid Rescue Task Force standard has been updated. I would suggest you review it. I know the battalions have been updated on it. And then we also updated the LVAD clinical standard, and it's really in line with what we talked about in the September MEC minute, so I'm not going to spend any time talking about LVADs today. That's it for the protocol revisions. Really, like I mentioned, most of them were small changes. We did make some major changes that we discussed earlier. Please take a look at the protocol and post your questions on Workplace. It's my understanding that the print versions are out there. They've been sent to the EMS coordinators, so you should be able to access the protocol and take a look at it long before it's posted to the phone app. Thank you.